My name is Numan Shah. I'm a consultant orthopaedic surgeon, primarily specializing in hip and knee surgery. I also do, as part of the NHS work in trauma and also look after people who've had certain sporting injuries as well. I've been an orthopedic surgeon now for over 10 years, primarily hip and knee problems that could be related to joint pains, arthritis. If people have got problems after their joint replacement surgery and require investigation or revision surgery, then that's also something I've specialized in. I studied in this great city of ours, which is Manchester. Went to University of Manchester and medical school here. One thing I will mention about the university is that one of the first universities that implemented problem-based learning, and that was found over time. It allowed the students that were coming out of that program to have not only the technical or the knowledge skills that are required that go with being a doctor, but also an impressive bedside manner, which was commented on in some literature pieces as well. I'm really grateful for the education I received there, and I found it a great foundation to build upon. That's a really interesting question. My instinctive answer was to be a doctor. I didn't say surgeon or physician or anything, it was to be a doctor because I felt that was the avenue that I needed to go down, and then wherever I would go and wherever that journey would take me, I would happily go down that road. In the UK, we work primarily in the NHS, but we also work in privately as well. My NHS work takes me to Salford Royal Foundation Trust, which is a major trauma centre. It's a university teaching hospital. I obviously practice orthopaedics there. I practice trauma surgery there. I'm also the lead for the 3D SPIN Centre, which is an acronym for 3D Surgical Planning and Innovation Centre, where we develop models for different surgical cases. And that's across a whole gambit of what we offer at Salford, which is anesthetics, ENT, orthopedics. And we're finding that when we use these 3D models, it allows us to develop solutions to them before we take patients into the operating theatre. What I enjoy the most, I must admit that I do enjoy the operating. That does give me a sense of satisfaction, fulfillment, and actually can give you quite instantaneous satisfaction, especially when you've got somebody who is, still working. They've developed really bad arthritis of their hip or their knee. They've been waiting a long time in the NHS, or then come and see me privately. They're in terrible pain, their quality of life is completely affected. They can't play with their children. If they're a bit older, they can't play with their grandchildren, they can't look after their family or help their family. And some of them do come to me, in tears. And just seeing them after the operation moving, albeit with some pain, but not the really bad arthritic pain, it's really gratifying and really satisfying. Over time, I've developed a repertoire of operations that I feel help my patients with hip or knee problems. Primarily, if we look at people with arthritis or joint pain, then there are a few operations that we can do. Primarily, that would involve injection therapies, which are procedures, total hip replacements or total knee replacements. Now, these operations usually can take about an hour to an hour and a half, but if they become complex, they can take longer. They can sometimes stretch to about 2 hours, particularly if we're doing surgeries which require revision surgery, which is where we have to redo the surgery, i.e. we have to take apart a hip or knee replacement that's been done previously, or there's infection, then that can take longer. That you're looking at then 3 hours, sometimes even 4 hours. But there are other procedures that we do, like osteotomies, which is where we break the bone and realign it before any joint replacement surgeries. And in a certain select cohort of patients, we can do that. There are other smaller cases that we do for trauma. Those usually take a lot less time. Like with any surgery, there are risks and complications. That's why during your consultation, I will go through those with you and explain those as fully as I possibly can, and also give you the opportunity to ask questions so we can clarify your understanding. With any type of surgery, when we operate, we are going to make an incision into your skin. That can obviously lead to bleeding. It can sometimes lead to infection. When we're doing the surgical approach, obviously, again, we're well aware of the anatomy. We know where the muscles, the tendons, the nerves, the blood vessels are, so we're careful to avoid those, but they can sometimes be vessels or nerves that we don't expect, and they can sometimes be damaged inadvertently, and that's something that we always counsel patients about and explain that if there was to be any type of complications such as that, what you would experience and what the longer term management would be as a result. The other aspect of surgery is the pain element. And some people think that, oh, I'll have the anesthetic and I'll be absolutely pain free. That's not quite true. During the surgery, you'll be absolutely pain free, and that's key and critical for us to be able to do the surgery. But afterwards, once you recover, you will develop some aspects of pain. But again, we've got abilities to inject the soft tissues around with local anesthetic, for example. There's certain patient-controlled analgesia machines that we have. And we've got other modalities that we can employ to help you with the pain. Thankfully, on a personal level, I've not had to deal with any significant complications for any of my patients. If things do happen, then that is the whole basis of why I've gone through so much training. And I've obviously seen complications from colleagues or my previous trainers and supervisors. And we have a certain regime or a way of managing these complications. My junior trainee surgeon, I always advise them that make sure that if there is a problem or a complication, you do share it with people and talk to the wider team so that you can manage that problem or complication in the best way possible. And by talking through that problem or complication, you will find the best way of treating that and managing that. Now, in my practice, I deal with various patients who come to me. Some are extremely fit athletes, marathon runners, and then I deal with other patients who may be wheelchair bound with multiple comorbidities such as diabetes, high blood pressure, asthma, lung problems, COPD, and also people who may be of a high BMI, which may be causing obesity. Now, each of these patients require a certain nuanced approach, and not one patient is the same. One patient may have diabetes, but they may not be obese or have a high BMI, whereas another person could be the direct opposite. You cannot manage those two patients the same way. So that is why I adopt a team approach. I have my anaesthetists who work with me, my nursing staff who work with me, and they review the patient if we decide to have the operation and manage those medical problems in a very comprehensive manner. If there's anything that we can improve or optimize, then we do that prior to the surgery. It could even mean that I send you to the metabolic clinic to try and see if we can reduce your BMI. It may be that I send you to smoking cessation service to see if we can wean you off tobacco. It may also mean that I send you to the physiotherapist to improve the tone of your muscles, to strengthen up your muscles and your muscle groups so that particularly once we do the joint replacement surgery, you're able to do the rehabilitation and withstand the surgery as well. So the type of surgery that I often offer is elective surgery. So that is planned surgery, it's not emergency or trauma. To that end, I always try and tell my patients that because I'm going to be improving your quality of life, it is important that we get you to the best health and mindset possible before any type of surgery. So that could mean that we optimize your medical condition. For example, your blood pressure, if it's running a little bit high, we can speak to your GP or speak to a medical physician and see if we can bring that down for you. If you're diabetic, we make sure that your sugar control is within the normal limits. If we need to tweak some of your medication, we do that. If we're finding that your weight could be an issue, then that's again something we can send you to the weight metabolic clinic, or if that's something patients want to do on their own, try and lose their weight, and that's something that we discuss. Again, if there's anything like smoking cessation that they feel they would like to do, then that's something I can signpost them to. It is important, for example, things like smoking, we try and reduce certainly before surgery, because we know that it affects your ability to recover after an anesthetic, and it can also affect how your wound heals and what outcomes you have after your surgery as well. So there are certain things that I do always advise my patients about, and then of course everybody's an individual. It is up to them to take that advice and take that on board. And I completely appreciate that. It's a very difficult situation to be in. And on the one hand, you have excruciating joint pain for which you require surgery. And on the one hand, you have your surgeon explaining to you the problems with, let's say, smoking tobacco. And I'm not very preachy in my clinics. My aim is not to see my patients and stop them cold turkey when it comes to these type of things. I'm a shared decision maker. I discuss with my patients and really find out their background and see, is there something that we can do about this? My job is to give you the facts. And at the end of the day, it is up to the patient to take those facts on board and do what they feel is most appropriate. But if you can get through that window of those few weeks of feeling a little bit terrible, I guarantee you in the longer term, during your surgery and after your surgery, you'll feel so much better for it. A lot of my patients after surgery will require physiotherapy input, and that's our standard way of managing these types of patients after joint replacement surgery. The physiotherapists are experts in what they do. They help the patients to recover with their mobility, simply standard day-to-day things such as simply getting and sitting up out of bed and getting out of bed, they help you with. And they will help you with how to use crutches preoperatively, so before the day of your surgery. But then they'll also see you on the day of your surgery, before you have the surgery, to give you advice and remind you about the things that you need to do when it comes to using your crutches safely, and also how to mobilize yourself with the crutches. For example, going upstairs, coming downstairs, and also they will guide you through your journey of recovery, allowing you to go from two crutches to a single crutch to then maybe a walking stick, to then achieving your independent mobility again. Some of my patients do find if they haven't got much reserve or as much muscle tone, then they may start using a Zimmer frame to start off with. Then they graduate to crutches, etc. But it would be my physiotherapist who would work with them before the surgery date, and also on the day of surgery and afterwards, throughout their whole journey, giving them advice of how to use these appliances safely. In clinic, when I see you, I will discuss with you the whole patient journey, from when we list you for surgery, the time of your surgery, and also the post-operative recovery period. And a question I get asked quite often is, how long will it take me to get back to driving, get back to life? And I normally reply with, it takes you about 6 weeks to recover from the main surgical elements of your surgery, which is the wound needs to heal, your mobility needs to start improving. You may be off crutches or you may still be on crutches at 6 weeks. Everybody's slightly different. So, and that varies. But at 6 weeks, you should be on that trajectory and gradually getting better. Pain should be improving, mobility should be improving, and that's what I would normally see you again in the clinic. Sometime before you discharge from hospital, the physiotherapist may identify that you may be somebody who requires a little bit more help and assistance once you're discharged. And they may institute that for you whilst you're at home, or they may advise you to come in hospital on a few days within those 6 weeks for a bit of extra input when it comes to physiotherapy. So at 6 weeks, I assess you and make sure you're on that trajectory getting better. Then there's usually another 6 weeks after that, i.e. 12 weeks after your surgery, which equates to 3 months, where you will then start to really turn a corner and get to a bit more normality. I also say that it can take you about 12 to 18 months for your body to adjust to the new hip or new knee replacement. And that again is just how our bodies work, how we recover and how the scar tissue develops and how our muscles recover and improve over time. Prior to embarking on surgery, I do get the patients to meet with the physiotherapists or the occupational therapists, and they will make an assessment after discussion with yourself how your home is adapted for you after your surgery. Now, none of these adaptations necessarily need to be permanent, but some of these adaptations can involve having a raised toilet seat. It could mean that you have certain grabbers that you can use to pick up things as they fall rather than you bending down too far and putting your hip or your knee replacement at risk in the early days. It can also mean if you need any adaptations to, for example, get upstairs, if you need any handrails, and things like that. And overall, we find that most of these things are temporary because as patients recover and get back to normal, they do find that they don't need to depend or utilize these things as much. My aim would always be to try and get you back to your normal activities, be able to manage your day-to-day activities, your work duties, etc. My feeling is if you are able to engage with the post-operative rehabilitation, people find that their recovery is much, much better. If there's any delay in that rehabilitation input, or if patients do not engage with it, then I do find that their recovery can be a little bit delayed. It doesn't mean necessarily that they will not have a good outcome. It just means that they won't get there as quickly as maybe somebody else who has engaged with that rehabilitation. And that aspect of it really pays dividends for you in the future. If you've engaged with the rehabilitation, even before your operation, you've got your muscles into good tone, you've had your surgery, and afterwards you're really engaged with the physiotherapist and you're doing the rehabilitation, I do find that those patients do recover sooner and get back to life sooner. Some patients, because of other limitations, are unable to do that, and I do find that their recovery can be slightly delayed. But overall, if I was to look at everybody in a year or 18 months' time, I do expect them to be back to driving if that is what they want to do, back to going on holidays, playing with their grandchildren or their children and partaking in activities that they weren't able to do before, for example, if they need joint replacement surgery. So that is precisely the aim here, is to get the patient pain-free and then restore their function as a result. No longer than a day, maximum 2 days. That is down to the type of operation that we carry out in those patients, but also to do with the anesthetic that we provide and also the rehabilitation that we do afterwards as well. Every patient after the surgery will see a physiotherapist. They will get them up, they will get them mobilizing, they will teach them exercises, and depending on how they progress and proceed, then they will be allowed to go home safely. Now, once they're at home, I would expect them to do those same exercises and rehabilitation that they've learned in hospital. And that is what allows our patients to have the best outcome possible. I specialize in looking after people who have been multiply traumatized or polytrauma patients, and there is a cohort of patients within that group that can experience post-traumatic stress disorder. We've got a very great team, both in the NHS and also on the private side, who can evaluate our patients and assess what are their requirements and what are their needs. The care that we provide to patients who may have gone through a particularly traumatic event, we start their recovery from the mental health side of things at the time that we are treating their physical problems as well. So it's at the same time, we don't delay things. Because one thing that happens with a lot of these patients is that their bodies have gone through that physical trauma, but their minds and their brain is still catching up. And we do find that a lot of patients have delayed reactions to the trauma that they've experienced. And if you're not one who has seen that before or not used to dealing with that, then that can throw you as a clinician sometimes. So I'm afraid that's a definite myth. You can, if you've had joint replacement surgery, depending on certain parameters, that if you have enough bone stock, that you physically can withstand an operation, and if you're willing to go through with another operation. Whereas, some patients may have a joint replacement surgery that's not working well, but they just don't want to have another surgery, and that may stop you from operating on that person, which is absolutely fine. And so those are the things that we do look at, but certainly, and that's again one of my specialties as well, that if there are problems with anyone's joint replacements, be them in the hip or the knee, then we can certainly look to revise them if there is indication to do so, and there is a certain way of how we manage those patients, and there's a whole workup. Again, we discuss it with a multidisciplinary team, and then we plan the appropriate method of how we can remove the old implant and then put in the new implant. And there's a very specific way to do that. But primarily osteoporosis means that your bones are getting weaker, and that usually occurs as one matures with age. And certainly there are things that you can reduce osteoporosis later on in life by making sure that in your younger age that you've put down enough bone and enough mineral content in your bone, and that could be by making sure you're doing enough weight-bearing activities like walking or physical exercise. I always say particularly women are more prone to developing osteoporosis, and that is more related to the hormones that women have and also the age-related changes that they can undergo. And that is why there's also treatment and medication available to strengthen the bones as well. Also taking calcium or vitamin D, making sure you're getting enough sunlight. All of those things allow you to have more mineral content in your bones and put you in good stead for the future. One of my main hobbies is traveling. I really enjoy that. Experiencing new cultures, new architecture, just seeing what that particular area, location, region has to offer. I'm going to say that's an easy one, and that's cricket. I do enjoy playing cricket locally, but also going to watch it and seeing it on the telly as well. I think it's definitely got to be cats for me. It's just that I seem to get along better with cats than dogs. That's an interesting one. I'm definitely right-handed, but there are many a times that I've had to, whilst I'm operating, use my left hand, obviously. And over time, you do become a little bit ambidextrous because we're operating on joints that are on the right and the left-hand side. I'd like to go with Ferrari. Not that I could afford one, but I would go with Ferrari more because it's a little bit more understated, a bit more subtle, just a little bit more classier. Mercedes, dependable, and I've got more experience driving a Mercedes than a BMW, so definitely Mercedes. Italian food. My wife loves Chinese, so we constantly chopping and changing. I've got to say, favorite dish is a difficult one because I've got a few, but I really enjoy lasagna, and that can be meat or veg, and that goes with anything really, or on its own. So definitely lasagna. It's really enjoyable. Thank you very much.